It is my honor to be here tonight to welcome you here. There are a number of important and moving speakers and communications and interaction to be held, which I'm sure will be very robust. Before getting going, I'm just going to make a few opening comments, if I might. So first of all, thank you to the people that do the work to put this together. A lot of them. Nancy Hans, of the Executive Director of the Prevention Council, thank you very much, and Tom Bowers, Salem Commonwealth Attorney. Dr. John Burton from Carilion Clinic's Emergency Medicine Department, who's the chair, who you will be hearing from. The many family members, friends, community members that are here today. I would presume all of us have been touched in some way by the issue we're here to discuss. And all the sponsoring organizations. These things require teams of people. They always necessitate lots of folks coming together, and I can't think of a more important issue and cause than this one for this group to come together. So thank you all for being part of this. I'll just cite a few quick statistics. There are different variants of these. Most of you are familiar with this, but I do think it's important to set a bit of a tone. 2016, 64,000 drug overdose deaths in the United States. After I read that and say it, I just always have to pause. 64,000 people, drug overdose deaths. Leading cause of death among Americans under 50 now, drug overdose deaths. Who would have thought that over the last 20 years? How do we get there? Over 100 deaths per day from opioids in 2016, up 19% from the previous year, from 33,000 in 2015, according to the Center for Disease Control. Projections, there are a lot of different projections. Those are complicated things to be sure of course, and so uncertainty comes with these. But some of the projections I read and look at that seem to have some validity based on where we've been, where we might be going, project up to 650,000 deaths over the next decade. These are unacceptable numbers, right? They should be unacceptable to everybody, to all of us, to government, to political leaders, to organizations. They should be completely unacceptable. So obviously there needs to be a movement on a variety of fronts. Understanding what's going on, why it's going on, identifying those in need and providing easy and affordable access to care with the best technology, the best ways to help. We need to stop deaths, obviously, but that's just part of it. That's not sufficient. To save a life is necessary and essential when somebody ends up in a situation with an overdose, but that is simply the first step. We need to be able to have programs in place to make sure it doesn't happen again. And we need to have funding and prevent reductions in funding that are proposed in a very complicated political world these days with a lot of needs and demands. It's not easy, but what could be more important than paying attention to the lives of American citizens in this country or young people and trying to make sure that funding is there. And communities like this community here play an absolutely critical role. So it's all part of the equation. You will discuss these things in some detail going forward this evening, and I'm sure you'll continue to make progress. I want to share with you briefly some things we're trying to do here for what we do best. And when I say here, I'm referring to Virginia Tech and Carilion, the partnership, the Research Institute, the clinical enterprise. You'll hear from Dr. Burton on the clinical side more. I want to tell you about some of the exciting research here at the VTCRI and across Virginia Tech in this area that we think holds promise. Many of you have met Dr. Warren Bickle and heard him at this forum before, who directs our Addiction Recovery Research Center, along with a gentleman, Dr. Matt Hulver from the College of Agriculture and Life Sciences. We just opened last week a new center for transformative research in health behaviors including how people make choices about things, such as choices about taking substances, and we're very excited about what that holds. You will be hearing in about a week or so a formal announcement that I'm not at liberty to give all the details yet, but I can tell you a little bit. Dr. Bickle from the VTCRI, Dr. Moeller from the Virginia Commonwealth University, Inova Fairfax Hospital, and major private industry have partnered together, and they're collaborating on a new transformative research project, an approach for treating opioid addiction for people who have overdosed and been revived on naloxone. This will be a new phase 3 clinical trial. It'll test a new treatment protocol that involves follow-up support and novel once-a-month formulation of a medication developed by a pharmaceutical company. They'll be working in conjunction with Emergency Department of Carilion Clinic, Psychiatry Department, Health System at VCU, Inova Fairfax, across the board and across the state. We're very excited about that. We think it offers hope and promise. For that trial, patients will be recruited into treatment immediately after they recover from an overdose. Treatment will begin in the emergency room with an active referral and transportation to an outpatient clinic where patients will receive investigational treatment and meet with a behavioral therapist. This is a very exciting multifactorial approach. Dr. Bickle and his colleagues hope to eliminate withdrawal symptoms and block the brain's opioid receptors, preventing people from getting high or continuing to abuse opioids. When people show up at the ER, once they recover from an overdose, they will get counseling without delay as well. In addition, there are other projects going on. I see some of my colleagues from Virginia Tech, Dr. Kathy Hosig and Dr. Sophie Wenzel are involved from the Center for Public Health Practice and Research and the Academic Health Department, and they have a grant from the USDA and HRSA working on opioid abuse prevention with the Virginia Rural Health Association Cooperative Extension, another important part of the research going on. Other investigators at Tech, including Carrie Redican and Valerie Reagan, from Population Health Sciences, are working with other groups on the problem. And they were actually invited to participate in a community opioid summit at Aberdeen because of the impacts and deaths due to opioid exposure in the military, including actually animals as well, police dogs. And this is part of what we call our One Health approach to the health of all of us, our people and animals as well. And believe it or not, this cuts across those areas. So there are a lot of things going on. I realize that's for the future. Many of you are here today and us are facing things that have already happened and are happening right now. And research always seems like it's out there. And we get that. But we have to get the right answers and the best answers, and we'll continue to work on them to try to provide the tools for the people who deliver the care and for all of you and for your families. So we hope things are going to change. As Ed Murphy, the former CEO of Fralin Clinic, used to say, hope is not a strategy. So hope is fine, but we need to do a heck of a lot more than hope. We have to work, and we are working, and we look forward to working together with you. And so without further ado, I'd like to invite to come to the podium Ms. Ray Barker, who will tell us about her story and her journey here, and I think the kind of moving stories that we're all here to hear about and inspire us and motivate us to do better. So Ray, welcome. You can use the hand.
Good evening. It is my privilege to be with you all tonight and to share a little bit about my story. Again, my name is Ray Barker. I am 22 years old. I graduated Salem High School. I grew up in Salem. And I'm going to tell you a little bit about my story with addiction. I am a recovering addict. So it is a miracle to just be standing in front of you all, and just such a privilege to be sharing a little bit about that. Growing up, I had a wonderful home life. I had a wonderful home life. Neither of my parents are alcoholics or addicts, although that is something that's rather atypical. It is a family disease. But growing up, I was really involved in school. I wasn't the kid that sat in the back of the classroom with her head down. I was really involved. I was a straight A student. I was involved in theater, choir. I was mayor of the Mayor's Youth Council. I was the kid that all the parents wanted to be friends with their kid, you know, supposedly a good influence, but I was living a double life. That really started after I took my first drink at 12 years old. I took that first drink out of my parents' liquor cabinet, which was wide open, unlocked, and ready for the taking. And I drank, even from the start, alcoholically. I drank to get drunk. I drank alone most of the time. I was really ashamed. Even my friends would not have approved of what I was doing. But from that very first taste, which started with curiosity, ended up being something that I knew I needed. It filled a void in me, perfectionism, feeling like I was always out of the group, feeling less than. Alcohol took all of that away, and that's where it began. I knew for the first time that this was something that maybe I couldn't control when I was on drug tests for the forensics team at Salem High School, and I knew that if I were to get caught drinking with alcohol in my system or any drugs, that I would be kicked off the team. This was something that was very, very important to me, and so I was telling myself, even as my parents left the house and I had the thought to drink, that I wasn't going to. I said, I'm not going to do this, not today. I was babysitting my little sister. And even as I'm telling myself not to, I find myself reaching to the fridge to pull out the bottle and poured myself a drink. It was scary, but it was something that I pushed down deep because I didn't want to think about it. Addiction is the only disease that will tell you that you don't have a disease. Eventually, my alcohol use turned into wanting to experiment with other things, became marijuana, and then I started stealing pills from my parents' cabinet. After that, I started buying pills. I had a boyfriend who was prescribed pills, and we started using them that way. Eventually, my parents started catching me. It was something that happened pretty much annually. They would catch me using. It would be very scary, and I would feel ashamed, and I would say, I'm never going to do this again, I promise, and I meant it. But I didn't stop. None of the consequences that happened and none of the risk that I was taking was enough to stop me. When I was 18, my parents got a divorce. Drug use was my only coping mechanism, and this was an unexpected and pretty traumatic event that happened in my life, and so I turned to drugs. That's when my daily use really started. I graduated high school. I still graduated with over a 4.0 GPA, but my friend groups started to change. I moved in with my dad and I started going to Virginia Western, but my use was daily and my life revolved around my use. Every paycheck that I was getting went straight to drugs. I had no bills to pay. I was living with my dad, so they went straight to that. Eventually, my life became unmanageable, and it was apparent I wasn't taking care of myself. I lost my job. I dropped out of college. And my parents saw an image of me that they had never seen before. I moved out of my dad's house and I was living with some friends. And again, my use was daily at this point. I moved to Richmond with a few friends a little while after that. This was in 2014. And I told my parents that I was moving to Richmond for music and for the culture and to get a new feel for a town, but really we all knew that it was for drugs. And there was really no denying it. Richmond had easier access, and it was a college environment at the VCU campus, and so it was a lot more accessible. So that's when my drug use took really a turn. I started really stealing to support my habit. I had done that to my parents. I'd stolen from my parents, which was really terrible, but I started stealing from stores in order to support my habit. I started selling drugs. So at this point, I'm a thief, I'm a drug dealer. These are not things that I ever saw myself as. I mean, I had hopes of going to medical school or law school. And so after that, I started, running drugs across state lines even. I was taking huge risks, hanging out with people, taking risks on my lives, mixing substances, and using a lot harder drugs at this point than just pills and marijuana and alcohol. And it was in 2015, I'd been living in Richmond for about a year. It was in 2015 when I went into a state of drug-induced psychosis that was brought on by the multiple substances that I was using for days and days at a time. My mom came and picked me up from Richmond and drove me to Fralin, where I was in their psychiatric facility for about a week. And my parents convinced me, they gave me an ultimatum basically, either I'm out on the street or I go to rehab. And I was telling them, I'm fine, there's nothing wrong, but I guess I'll go to rehab just to, save myself. Once I got there though, I started to identify with other addicts. I realized, oh, I'm not by myself and I'm not crazy. They're telling me that I have a disease, which was honestly a relief. I thought that this was just a way that I was going to live for the rest of my life, and I was told, no, there's a solution. So I moved back to Roanoke. I was living in a sober living facility and things were going well. But again, the disease of addiction told me that I don't have a disease. And while I admitted that I was powerless over my addiction and that my life had certainly become unmanageable, I thought maybe I can still do this and control it. Maybe I can just have one beer one time. I mean, I just turned 21 years old and I was rather resentful that I would never be able to drink alcohol again. So after 5 months of sobriety, I relapsed. And it started with alcohol, and it led to marijuana, and I was right back to using the substances that I was before. I quickly became homeless. I ran away with a total stranger, where we lived homeless in a tent in Culpeper, Virginia for a couple months. The relationship became abusive and violent. And I was in a situation that I swore I would never be in. I said, I'm a confident, independent woman who knows my worth, and I will never get caught up in an abusive relationship. But I was high and desperate, and I stayed in it for a lot longer than I should have. I left him in a broken state, and I moved to Richmond, still not ready to give up the drug use. I lived homeless in Richmond. I slept on a park bench once. It was the most desperate time of my life. I went to a music festival, and I met a group of people there that loved on me and told me that they loved me no matter what happened, and they just wanted the best for me. And they brought me back to Roanoke, but still I couldn't stop using. So I once again, for the second time in a year, went into the hospital for drug-induced psychosis. Both times the doctors told my parents that I may never be the same again. It was quite possible that my brain would have been permanently changed from all the substances that I was using. But it was in the hospital that I have what people in my community call a moment of clarity. A fellow recovering addict came to me and shared a little bit of her story, and it was then I realized I need long-term recovery. I need a long-term residential treatment, about a year. And as God would have it, the Rescue Mission Recovery Program was having an intake that very weekend. They only have one once every 2 months. And the recovery program was having an intake the very weekend I was supposed to get out of the hospital. So I went bed to bed. I went immediately into the Roanoke Rescue Mission. And that's where I've been for the past 13 months. So thanks to God and to my 12-step fellowships and to the Rescue Mission Recovery Program, I now have over 13 months clean and sober. Thank you. Thank you. It really is a miracle that I am alive. I am not in prison. I'm standing before you, a healthy, confident young woman who is healing, because this disease is one of the body, mind, and spirit. And as you can see, it can take a person to places that one would never, ever imagine. But today I have hope. I have dreams. I'm going to go back to college for the spring semester. And so recovery is possible. But if we can prevent this from happening before it even starts, that would be the best option. Because it took me going to the depths, as you heard, the very depths of desperation before I was ready to recover. So I thank you so much for listening to my story. And now I'm going to introduce Joe Crowder, who's going to give a presentation on opioids and opiates. Thank you.
Thanks, Joe. Will this have any feedback? No issues. Can everybody hear me? Loud and clear? All right. Like Ray said, my name is Joe Crowder. I'm a special agent with the Virginia State Police Bureau of Criminal Investigation, specifically assigned to the Drug Enforcement Section, which handles all narcotics investigations, assigned to the Roanoke Valley. Just raise your hand if you are directly or indirectly right now affected by this epidemic. Do you know someone? Just about everybody in here, right? All right, so I'm going to bring it close to home. For the first 8 months of last year, we had 77 overdoses reported to us at law enforcement, okay? And that includes non-fatal and fatal. For the first 8 months of 2017, I'm not happy to report 277. Are we winning the fight? Mm-mm. We're not. But we're getting there because of presentations like this and people like Dr. said is working very, very hard. But I opened this presentation with that stat. And I'm not big on stats, but it hits home. It hits home. That number is growing. by the way. 27 of those were fatal. In a 24-hour period several weeks ago, we had 5 deaths right here in Roanoke. Okay? We worked around the clock, and I'll commend the men and women in law enforcement working around the clock to identify the source of that lethal supply, and we're still working it. Okay? So, that being said, I'm just going to read a couple of things before I get into the PowerPoint. Anybody know what demographic right now in this country represents the fastest growing first-time heroin user? Does anybody know? Age, gender, race. Can somebody tell me? White female between the ages of 20 and 25. And where does that female live? Suburbs. All right. High school age kids. After marijuana, does anybody know what the 3 most abused drugs are for our high school age kids today in this country? Vicodin, Oxycontin, and Adderall. And we're going to talk about fentanyl. Those are the 3 most abused for high school age kids today, after marijuana. 95 million Americans used painkillers last year, more than tobacco. I saw that just the other day. It's mind-blowing. More than tobacco. I never seen that before. Fentanyl seizures, like the young lady said over here. Of the top 10 states of fentanyl seizures, where do you think Virginia ranks? We're 7. As law enforcement last year this time, we were seizing a 2-ounce seizure of fentanyl. Now we're seeing kilograms of fentanyl coming right here to our backyard. Okay? So the fight continues. All right. Where's my clicker at? There we go. All right, so here's the discussions. The rise of opioids. We'll talk about that. The path of a monster. The progression of opioid use to potential heroin use. We'll talk about heroin and fentanyl. Identifiers we'll probably skip around tonight. Overdoses, the community, and parental denial. All right. Prescription opioids. They're man-made painkillers such as hydrocodone, oxycodone, Percocet, Vicodin, Dilaudid. The opiates are the natural pain relievers derived from the poppy plant, which is heroin, okay, morphine. Man-made synthetics, obviously, are your non-prescription drugs such as fentanyl, which is a synthetic opioid. And we'll talk a little bit more about that in a minute, just so you know. All right, so how did we get here? I think most of us kind of have a good idea of how we got here, but let's breeze through it, okay? The overprescribing of painkillers in the 90s. The decriminalization of marijuana decreased the cartel profits by 40%. So what is that? It's pretty simple supply and demand, right? Americans become addicted to painkillers. We decriminalize or legalize in some way, shape, or form marijuana in this country. That's just an argument, okay? They saw that we were addicted. They saw that they could actually offer something with a little bit higher purity, all right, a little bit cheaper. So they flooded this country with heroin. The overdose rates between 1999 and 2008, they soared. 15,000 Americans died from opioid overdoses in that 10-year period. 254 million opioid prescriptions were filled in the United States in 2010. 254 million. Opium production increases in Mexico, increases by 50%, obviously supplying the appetite for America's epidemic. In 2015, 52,000, like the doctor said, some change, Americans died of the overdoses. The CDC will not report for 2016 until December of this year. They are projecting over 59,000, probably close to 64,000, I think someone said earlier. In 2017, they are already predicting that to be worse. Okay? All right. Have you ever used an opioid prescribed by a doctor? I have. Anyone is prone to the brain disease of addiction like Ray was talking about. People addicted to prescription opioids are 40 times more likely to become addicted to heroin. I was in court today. There was 2 people testifying, and they were talking about their past drug use, and the prosecutor was asking them, hey, how'd you get started? It's like a broken record. I started with pills. I started with pills. I started with pills. We hear it time and time again. Okay? Our unused prescription medications housed in your medicine cabinet. And this is a good point, okay? Think about the people that have access to your home. Obviously your kids, obviously other loved ones, family members, the TV guy, the maid. The list is long, right? Do you keep those locked up? Or do you just keep them in the medicine cabinet, in the nightstand? Things like that, easy accessible, right? Well, trust me, guys, kids, I'm telling you, and I speak to them, I get this from interviewing them. This is how they grab this stuff. A lot of times they get it from family members. Ray will attest to that. Okay? So just be mindful of that. If you have them in your home, legitimately prescribed, keep them locked up. Monitor those things, especially you parents with your kids. If they're prescribed a painkiller, you need to monitor that, right? All right. This kind of says it all. 2015, opioid deaths surpassed motor vehicle accidents and gun deaths in this country. All right, it's pretty simple. We've heard it kind of time and time again, but that's the graph right there between opioid death and motor vehicle deaths and gun deaths. 2016, the opioid death projections surpassed casualties of the Vietnam War. That, to me, it just kind of nails it home. We lost more than all of our soldiers in the Vietnam War. All right, so probably the best slide of all the things we've done. This is one of the best slides. Just read this and let it sink in for a minute. Americans represent only 5% of this world's population on planet Earth, right? We consume 80% of the global oxycodone and 99% of the global hydrocodone Americans. Just about all of the hydrocodone we consume. The U.S., Americans, also use 2/3 of the world's illegal drugs. And that list is long: cocaine, methamphetamine, ecstasy. All right, so the path of the monster. How does this start? With prescription, a legitimately prescribed painkiller by a doctor for an injury, pulled tooth, whatever the case may be. We also have it on the right here is experimentation, or what I call fitting in. All right? Maybe somebody trying to self-medicate some sort of anxiety disorder. We hear that from some of the kids, that they started using pills to relieve some anxiety. How many of you guys ever heard of Skittles parties? Farm parties? I asked that to the high school kids, and when the hand's raised, it's eye-opening. Our kids are attending some of these pill parties, where they get a bunch of pharmaceuticals from family friends or street dealers or whatever the case may be. They hold these parties, and everybody grabs a handful of pills and drinks beer. Okay? So it can start a couple different paths. The opioid abuse starts, you become addicted to opioids, you build up a tolerance, there becomes a financial limitation, and it gets difficult to get. It becomes difficult to get, but you're addicted. So what substitutes an opioid addiction? Heroin. Heroin. Much easier to get. It's cheap. It's got high purity. The dangerous part is what's added to it. And we'll talk about that. All right, so heroin supply and demand, the methods of use. What we see here mainly is people begin to snort it, okay, because nobody likes to put a needle in their arm. But there's an easy transition, depending upon who you're hanging with, right, Ray? Where you transition from snorting to powdered heroin to where you put a needle in your arm. And that opens the door to a whole lot of different things. All right? Source of drugs, criminal activity, medicine cabinets. I like to talk about criminal activity just because I represent law enforcement. 9 times out of 10, when I talk to these people who are using drugs, it's usually in a holding cell, on the side of a road, where either an arrest is getting ready to occur, or what have you. All right? These people steal, they rob, they break into cars, they steal cars, they jump over CVS counters and rob people at gunpoint, whatever the case is. And the reason why they do it is to fuel their drug use. They deal the dope to support their habits. And then they get caught up in big old conspiracies where we come into play and people go to prison. I see it all the time. All right, so addiction. It's a brain disease. Are you playing Russian roulette? With heroin, are you playing Russian roulette? With a 30 milligram Oxycontin, do you know what you got? You know what you got, right? Bag of dope, do you? No. All right, so the result, obviously, is overdose death, or if you're lucky, you're in jail. How am I doing, Tom? Good? All right. So, all right, myths and facts. A couple important ones. Is it less addictive to smoke or snort? We have high school kids that think that snorting it, you can't get addicted. If you just snort it, you can't get addicted. Can you overdose by snorting it? Absolutely. Fact, risk of HIV, hepatitis is lessened when not using needles, but every method of use is highly addictive. Heroin users are older. I didn't say this to begin with, but I usually always open up our presentations with this. Look what the average age for a first-time user is now. 21 years old. Just a couple of years ago, it was 23. What's that telling us? Getting younger, isn't it? Got high school kids and middle school kids in the Northeast that are testing positive for heroin. Scary. You become addicted with a single use. Is that true? That differs, actually. I've asked that question to a bunch of people, and most of the time I get this answer. It's a process. It's a process. All right, so heroin is an inner city problem. Is that true? It's not. It's suburbia, guys. It's out here in your middle and wealthy class. We'll get around that here in just a minute. All right. Heroin and fentanyl. You need to know the difference, and a couple of things that we need to point out. So heroin is no medical use, typically seen as a gray or black powder, mainly a tan or what I call rose gray color, white in its purest form. It's known, the black sticky substance known as black tar heroin that you see mainly out on the West Coast. It is starting to be seen more often east of the Mississippi. This is an interesting thing. The reason why they don't have a lot of overdoses out on the West Coast, at least it's not as many on the East Coast, and this is very, very interesting. Black tar heroin is mainly the substance that they use west of the Mississippi. The Northeast and the East Coast and the Southeast, we mainly use powdered heroin. Fentanyl is not in black tar heroin. Making sense? It does, doesn't it? Now it's starting to slowly creep out towards the Midwest. Anybody know what the 5 states that have the highest rate of overdoses per capita? Anybody name one of those 5 states? West Virginia. Ohio. Kentucky. New Hampshire and Rhode Island. Okay? Think about those geographics where you're just sitting there thinking about what they're geographically located. All right, so fentanyl. Produced by street chemists, mainly from China. 30 different analogs that we know of. It's a little bit over 30 now, but you know what the potential number for fentanyl analogs is? That we know of. 1,400. 1,400. There are now 2 analogs of fentanyl that is resistant to Narcan. Somebody just told me the other day, the scary part of this is this. There is a rise in deaths, and the effectiveness of Narcan is going down. It just is what it is. This is a scary, scary thing. All right? Frequently disguised as prescription opioids. We talked about this last year, these Xanibars, these Adderalls. We were just talking about it last year, say October of 2016. It's been a long, hot summer, folks. Now these prescription opioids that are counterfeit and are pressed with fentanyl are popping up everywhere here. They are now here. We talk to these addicts, we talk to these dealers, and we see the cell phone dumps, and we see on the cell phones and the text messages they're talking about, give me the pills, it's pressed. Give me the pills that's pressed. You know what they're talking about? They want the Oxycontins that are pressed with fentanyl. Okay? All right. Methods of use. Smoking, snorting, shooting, we've already talked about. Here's something that's just, it kind of hits home. Over 80% of heroin users who inject the drug do so with a partner, and yet 80% of overdose victims are found alone by first responders. That is very, very true. Very, very true. Street packaging, just so y'all know, okay? This is a bag, or AKA, it's also known as a dose unit. Small little wax fold, about that big. Those are bundles of heroin packaged in that we seized on a controlled purchase and an arrest. Those are what we call 10 packs. They're just 10 bundles or 10 dose units, rubber banded. You see the marketing. We had a stretch there where we started seeing a lot of the dose units, these little bags here, being unmarked. They were just plain, what we call plain whites or plain blues or plain yellows, whatever the case may be. The reason that was is because you had a lot of the street dealers or a lot of traffickers from the Northeast. They didn't want those stamps to be tied back to them in case there was an overdose. That's what we saw. Now we're seeing these stamps come back. Now they're everywhere. Right, Scott? Starting to see a lot of that, right? All right, so identifiers for police, we're able to track those back to some of the dealers and make some big cases. Unfortunately, these are the calls that we answer. These are the calls that we answer. Okay. It's tiresome. It's tiresome. 24-hour period, not too long ago, that's what we answered. And folks, this is not in some far distant land. We can buy heroin in Hunting Hills. We can buy it on Keggy. We can buy it on Rugby Boulevard. We can buy it on Plantation, Benton, Main Street, Salem. It's everywhere. There is no community. You cannot live in this valley where you're immune to this. Ain't gonna happen. Ain't gonna happen. So, before you came here tonight, and if you could, visualize a drug addict. Is this what you envision? A lot of people I deal with look like that. I'll be honest. But you know what? When we answer the calls to the ERs on overdoses, when we go to a lot of these fatal overdose scenes, or some of us go to a funeral home and talk to a mother and father after losing their child to an overdose, this is what we see. Right here. That's what we see. I turned 45 last month. Not scared to say that. I lost my 9th classmate just a few weeks ago. Mainly, most of my classmates have been lost to suicide, a car accident, cancer, like a lot of us, right? 45-year-old died of a heroin overdose. Childhood friend of mine. I don't see that very often, that age group, quite honestly. But there are kids in this country today at 21 and 22 and 23 years old, upon graduating from high school, have lost 25 and 30 classmates due to this epidemic. That's very true. The truth about Narcan, are we saving lives? But we are failing to stop the overdoses. The enabling argument. Huge debate about naloxone or Narcan, right? Can we deny someone of a life-saving drug? Can't do that, right? We're not in that business.
What if they just did something where 3 times, I know a couple places are saying if they answer the call 3 times, after that they're not going to administer it.
Yeah, that's fake news. Yeah, you can't deny someone a life-saving drug. We're just not in that business, guys. We can't do that, right? Think of it in this term, all right? And this is a huge debate. We can talk another hour about this. But that Narcan administration could be that stopgap where someone receives treatment, they found that moment of clarity, and they live to fight another day. Now look, if there's any cops in this room, which I know there's a couple, we get cynical at times. I'm going to be honest with you. Because we see the same individual over and over and over and over again. One female that comes to mind, I know at least 8 times. But they jump off that gurney in the ER, and they're back in that hotel room, or they're back out there to that residence in South County. And I'm just using that as an example, okay? Using again. We have those people. We have those people. And it's frustrating. It's very, very frustrating. But here we go, with all the different analogs and stuff in fentanyl right now. And I just had an EMS guy tell me the other day, sometimes it's like using a squirt gun in a house fire. And minister and minister and minister to some of these individuals, to not know what kind of substance is in their bloodstream, what's causing this and what's causing that, and it's hard to get some of them back. We have some dangerous substances out here right now, okay? So, it's just an argument, guys, but it's out there, it's saving lives. Our non-fatals are much more than our fatals, and the reason why is because of this. I'll tell you that right now, it's because of Narcan, all right? And we have people working hard to, when people are saved, to get these people treatment. All right, parental and community denial. What, I got about 1 minute?
1 minute.
1 minute. All right, so parental and community denial. Addiction or a crime, the culture and stigma must change. What's a risk behavior? Unrestricted cell phone use, the internet use, and gateway drug use, marijuana. We don't have time to talk a lot about that. What are we going to do about it? We will talk to every church, school, and organization, and like somebody told me, if you want to talk in a phone booth, by God, we'll be in a phone booth to talk to you about it. We've got to get it. We've got to get it out there. We can't whisper about it, okay? We can't do that. That's not working. And we educate our parents and our kids. That's what's working. We're not there yet, but we're getting there, okay? A lot of parents have come to me since October, and Nancy and Janine, and said, hey, we didn't make it last year. We know some people's having some problems. We want to be educated and know more about this stuff. So people are coming forward and they're talking about it, and that was our goal. So here we are. All right, I'm going to have Tom at the end of this talk about your resources. Okay, Tom, I don't want to go into this because this is extremely, extremely important that you know if you have a problem or you know someone has a problem, what resources are at your fingertips. Use them, guys. You got some hardworking and dedicated people out here that's going to do that, okay? All right. Path of heroin addiction to opioid use is easily found. We must stop them from reaching heroin. The time for prevention is now. And we'll just leave it at that, okay? We'll leave it at that. Hope you guys have some good questions. All right, I'm honored to be here and represent law enforcement, number one, because hey, we're fighting this thing every day, all right? And I'm happy to be part of this group up here, okay, because there's some hardworking and dedicated individuals. So thank you. Guys, I want to introduce Mr. Gilbert, who is a father. I'm honored to sit here and listen to him.
Jordan.
Jordan, my daughter, was a great daughter. She was a great sibling. She was a great aunt. She's a great person, very smart, very articulate. Probably, I've got 3 kids. I had 3 kids. Probably, and you can't say one smarter than the other, but she had the most raw talent, the most artistic flair than my other 2 kids. Love them all. They all have a good side of it. But Jordan just had something that was not clicking right. Jordan started, like you said, with pot. You think pot's not bad? You know, and I came up in the 70s. I came up in the Vietnam era. I know what pot was. Now, what's out there today is not the same thing. But Jordan started on pot. Then it started on Xanax. Then it had to start someplace else. And she ended up with heroin. You know, and so remember this. You know, it's very addictive. I mean, it's an addiction that anybody can have. You know, I was on a lot of pain medication. I've had a total hip, total knee, 6 other joint surgeries. So, you know, and I'm part of the issue because I was not one of them that hid my drugs. You know, and it is an epidemic. I mean, I've got friends and people that I know that right now are on things. One of them had 6 doses of Narcan to bring him back. But Jordan, she was very soccer player. She was doing it all, and she was good at everything that she did. But it got to the point where she stopped coming to family events, to dinners, things such as that. And the pot, is where it starts. Started hanging around the wrong crowds. We talked about that. Some of the people that were her friends, I met them they came in, people that did drugs with her. It's the hardest thing for me to do when they ask you to forgive them. But remember, as a parent, you got to temper your reactive behavior. I didn't always temper mine. Jordan and I was a lot alike. If it hit here, it came out here. We loved each other, we hugged each other, we talked to each other every day till March the 26th. But if you've got someone that's having problems, get them to seek professional help. We did get Jordan help. On and off, we had her in 30-day facilities. My belief is some people, like Jordan, needed 6 months, a year. It's not something that can be healed in 30 days. If it was, she would have been healed. And counting, some of the just seeing a doctor, my wife and I sat in and talked about 10 facilities. 10 facilities. Now, that wasn't just 30-day facilities. That was in and out treatment, whatever, over at Lewis Gale or whatever. But some people have a deeper issue than others. Joe always told me that she felt she was bipolar. I, as a parent, don't listen to kids. I said, no, you're not bipolar. Today, yeah. I didn't listen to her. You need to encourage productive behavior, grades, artistic things, keep them, creative. They got to be accounted for the negative behavior too, though. At times I was a single parent, and I didn't follow up. I did not do certain things that I should have done. Early on, she did steal my pills, I would be there in a bedroom because I couldn't go upstairs and be asleep or whatever, and pills started, going away. So lock them up. Don't tell me that they can't get them. If I had it to do over again, every one of mine would have been locked up. I got to the point where I dealt with the pain. I took the medication, poured it down a toilet, and never used another pain pill. Cash, Jordan was having struggles, so I was helping her out. I got to the point where I wouldn't put $4 or $5 into her account to get a pack of cigarettes or whatever. Don't give cash. I took her to Kroger. I took her to these places because I couldn't trust her with money. Never leave your child without some type of option. You got to give them options. You got to give them the ability to make some decisions. But I withdrew her options the night before she died. Wouldn't let her come home. Wouldn't let her go to her sister. Wouldn't let her do this. So she went to the only place that she thought she could get a bed, and that was with someone she did stuff with, a number of months before. And she went to Hallihurst in Fenton, and she died there. And you as a parent, if you suspect something, it's probably something going on. I suspected it, but I didn't always react on it. Red flags, you start losing things. You start missing things. Pawn shop receipts. There's something going on. And a drug addict or a person that's doing something wrong, their best defense is an aggressive offense. No, fight, argue, take, shield the blame away from them. Blame somebody else. So that happens. She was trying to get clean. There's no doubt in my mind she had not been on heroin for a while. And she didn't die of heroin. She died of methadone. And she was trying her damnedest to get clean so she could go to Dove's Nest in Charlotte. That's a facility down there that she could have gone to and been, 30, 60, 90 days, maybe 6 months. They evaluated, and she got so desperate that she went to this person's house, and that's when it happened. As far as I know, she had never done methadone before. Now, I don't know, but I think it's true. I don't think she had done methadone. She tried to do something to take the pain or the wane away from her. The person's house that she was in, there may not be anybody there, but my daughter laid in bed dead for over 7 hours before the woman called for help. My belief is she was cleaning the place, helping her own self. So these people that your kids are hanging around with, they can't be trusted. Some of them. I mean, you got good kids out there too. I don't mean to put everybody in the same, but she made the wrong. My daughter made a bad decision. And I made a bad decision. If I had to do it over again, I would change, but I don't. And those 90-day facilities, 120 days. But I can tell you, I know without a doubt that my daughter's death saved somebody else. One of our family members took the Narcan training. And she had a couple doses of Narcan. And she ended up giving it to somebody else that ended up giving it to someone that was having an overdose. So my death, my daughter's death, did save somebody. One of the things that I would like to see changed is some of the facilities that they do not let you come in unless you're clean. And I'm thinking, duh. I mean, if you need help, you need help. Why do you have to, expect somebody to be 100% clean to get into a facility? That's wrong. And there's only two ways. If you're on drugs and you're on, heroin, you're on methadone, there's only two ways out. Get clean or die. And take your child, hug them, kiss them, love them. Don't give up on them. I think at that point, I'm not going to say I gave up on them, but it's hard. It's a struggle when you're fighting a daughter with addiction. But I can tell you, there's no doubt she was clean off heroin. She was not on heroin. She did go to some place and took the methadone, and she passed. And that's a picture of my JoJo. Extremely artistic. So don't think that those faces that Joe showed you a minute ago, they're not all like that. And my daughter looked like that second picture, but not when she was having her overdose, and not the last few months. So I'd like to say, kiss your kids, love them, or your family members, not just kids. So I'm going to leave it at that, and I want to thank you for listening to me. Do try to help anybody that you can, and I'll answer questions if I can later, but what I'd like to do right now is introduce Dr. John Burton. Thank you.
Well, that's a difficult story to follow. So let me just kind of gather myself for a second. Okay. So I always enjoy listening to Agent Crowder. His slides and his grasp and understanding of the topic gives me tremendous comfort knowing that we have people in law enforcement and on that side of the equation who have that level of understanding about what this is all about. I don't know about you, but one of the most difficult slides there and one of the most difficult photos in that slide set is in the upper left-hand corner of one of his last slides there. There's a person injecting themselves with a needle. And if you saw that slide, when I see that slide, and I've injected needles into people thousands of times. That's what I do. I'm an emergency physician. I'm the chair for the Department of Emergency Medicine here at Fralin Clinic. It still gives me the willies to look at that and think, you know, how could I possibly ever inject myself like that person's doing in that slide? And I can't help believe that's what you think as well about yourself and about your families. And that's one of the hardest things in awareness, is to get people to understand how you could get there. How could you possibly get there? How could your daughter possibly get there? A young woman of that beauty and intelligence, how does she get there to where she's injecting something in her arm? Heroin, fentanyl. How does that happen? The second thing that's really hard for people to understand and get their head around is the force of the opiate addiction itself. The grip of an opiate addiction is unlike anything we understand unless you're in the middle of the grips of it yourself. One of the things that helped me understand just a part of the addiction itself and the grip and the force of that is that if there's substances in your life that you use, alcohol, cigarettes, whatever your vices are, and you do them to excess, you never go below zero with those things in terms of the next morning using them to return to a normal state and then continuing to use them to a normal state. We think about that with alcohol. We think about that with tobacco and using that to address the cravings. But for opiates, the force of the addiction to get back to a normal state is a terrible place to be. It's vomiting, abdominal pain, sweats, diarrhea, and the person who is in the throes of that below zero existence when they're not using opiates after they are addicted, they are desperate to get opiates back into their system because they know that will fix their problem. Now again, it's easy to make the equation of cigarettes or alcohol, but I can assure you that the person who is trying to get their nicotine fix or is trying to get the hair of the dog that bit them with alcohol is nowhere near thinking they're going to die in the next couple of hours if they don't get that fix. Literally die. And that's the way an opiate addict is. They feel that they're totally going to die. So one of our strategies here over the last year, 2 years, as we've had public events like this, has been to get out and describe, put a face on the problem, put some statistics, put some numbers to the problem, anything that we can to get out and get people to understand the truth of this problem. For me, a statistic that may be helpful for you is in 2016, we had almost 1,600 deaths in the Commonwealth of Virginia, and that exceeded the number of deaths we had from car crashes. As Agent Crowder showed in his data, the number of deaths from opioids in the U.S. and in Virginia is now exceeding that of motor vehicle crashes. So if you worry about your children or your family members or yourself when you're out driving, you've got a higher risk of those people in terms of just the pure numbers of those people dying from opioids at this point. The second thing is that if you think about motor vehicle crashes, you can think about that as anyone can be affected. You don't think about rich people or poor people or uneducated or college educated or older, younger. It's the whole swath has motor vehicle crashes and are at risk for that. Certainly there's risky behaviors, and that's certainly the way that opiates are now, is that everyone is at risk for them, just in the same as we are from motor vehicle crashes. So as we raise awareness, where do we go from here? So a couple of thoughts about that from a doctor's perspective and emergency physician's perspective. One, money. We need federal funding, we need state funding, we need local funding, we need foundation funding, we need money, and we need it now. And we need to have our people in positions to influence funding in the public sector and in the private sector to put some money to the death count. When you start seeing numbers like the deaths are exceeding those in Vietnam, and you think about all the money we wasted on that conflict, just give us a hint of a fraction of any federal dollars to affect this and the things that we might be able to do. So if you can speak to your elected representatives, to people you know who may be in a position where they influence the flow of funds at a federal or a state, a local, or even at a foundation level, find targets to spend that money to help this problem, because it will affect you, and that money flowing to those opportunities is one of the options that we have. Second, law enforcement. Law enforcement here is critical. Supporting our law enforcement, again, with money, more officers, more training, more abilities, and with their time to get them out to help shut down the supply, the borders, whatever it takes to get the illegal drugs off of the street is going to be an essential part, as well as policing the activities and the individuals. 3, supply. When you think about law enforcement, you think about illegal supply. There's a whole nother supply that's got on a jacket in front of you and a tie, and that's physicians. If you would have asked me in 1995, can you get addicted or have addictive tendencies after a 2-week prescription that I give you in the emergency department, or after orthopedic surgery, or after general surgery, I would have said absolutely not. If you said, what about 1 month? I would have said no. I would have said 2 or 3 months at best. The latest data coming out of the Centers for Disease Control, the CDC down in Atlanta, shows that addictive tendencies from doctor prescriptions that are connected to lifelong addictive behavior to opioids start on which day of that prescription? Day 3. Day 3. Now that doesn't mean that if you go in and you get a knee replacement, or you have a car crash and somebody puts you on pills, that on day 3 you're going to get addicted. No. What it means is that there are certain people who are more prone, as we heard tonight from Ray's story, who are more prone, more likely, and they will start their addictive tendencies on day 3 is what the data is showing us. And every day thereafter, you can see breaks in the data out there at day 10, day 14, and out of day 30, there's correlations with like 20% of people showing long-term opioid addiction therapy. So back to the problem is physicians and prescribing. So a lot of people, when I talk to them about this problem, they say, what is Carilion Clinic doing about it? And what I can tell you is that Carilion takes this problem very seriously. For the last 2 years, we've continued internal task force on prescribing and trying to ratchet down and focus our prescribing on not only numbers and quantities that we prescribe, but also to whom we prescribe and strategies for who we should be prescribing to. In our department, in our emergency departments, our prescribing has dropped by 65%. The number of pills that we send out. The tricky part of that, though, is there are people who need those medications. There's somebody with kidney stones. There's somebody with chronic pain and cancer pain, and we can't let them fall through the cracks either. So we can't get to 0 in physician prescribing, but we've got to get to an understanding of more responsible prescribing. So that's all about supply. You've got to understand the connection between the gateway, the opioids, and the pills that we've identified as being high drugs of recreational use now, oxycodone, hydrocodone, and that pill supply, then translating to the photo of the needle in the person's arm, because that's how you get to heroin. You can't get your pills anymore, so then you have to have your addiction, you have to have your fix, and that's heroin. Last point that I would make is treatment programs. We do have opportunities. We've got a lot more questions than we have opportunities, but the opportunities exist in things like the Suboxone treatment programs and expanding those. Faith-based programs that have shown some opportunity and initiative, and funding and expanding those. Other programs that demonstrate any opportunity for improvement and outcomes-based improvement, we need to be pursuing and supporting those with dollars and with efforts, because those are solutions to those who are called up in this addiction crisis, and we will have many, many more who need that therapy moving forward. Innovative therapies, like Dr. Friedlander talked about tonight, offer opportunities. One thing we still can't figure out, and this is what I'll close with, is when your son or daughter or mother or father or neighbor, or maybe soon, a few years from now, you get brought into one of our emergency department in full respiratory and cardiac arrest after you or one of those people overdose on heroin or fentanyl or methadone or whatever your opioid of choice is, or that person's opioid of choice is at that time in the future. We still can't figure out how to take that teachable moment right there, when they're right there, and translate that into long-term survival. We fail at that literally every day, every minute now, with the scope of this problem that we have in the country. And that's another key thing that we need to figure out, how to intervene to make a difference long term. So it all becomes supply and treatment strategies and understanding the full scope of the problem. So thanks very much for your time. I'm going to introduce Tom Bowers, Commonwealth Attorney for Virginia. Thank you very much.
Okay, well, thank you very much. And I guess 4.5 years ago, I was kind of picked by local law enforcement to be the chairman of this task force, and nothing would make me happier than to work my way out of this job, but I don't see it happening anytime soon. But we've got a great group that are willing to work for it. As the slide said, we will go anywhere. We'll go to any church. We've really kind of started just recently kind of saying, well, maybe we need to get into the churches. And I'll tell you that 2-3 weeks ago, Janine and Nancy and I spoke at my church, and it was interesting that a month before, when they announced that we were coming, a week later, we had 2 deaths in our church. One of them was Joe's friend who played in our praise band, and then another one was a grandson of some church members. And so it kind of shocked our church. And the result 3 weeks later is we had 170 people for our presentation. But I think it was very important too that what my minister said that day when we the first Sunday back from having 2 people in our church pass, and from the member of our praise band, Joe's friend, they had a little thing by the praise band with his, I don't know, the big was it oboe, bass, or something. I don't know anything about music. And it was a very touching picture. But my minister said something that just has hit me like a ton of, he talks about, the Bible, they talk about the Good Samaritan and all the people walking by, and somebody is in a ditch and they need some help. And then finally, people walk by, and finally the Good Samaritan comes. And that's what we've got to do. We've got to all be Good Samaritans. We've got to start looking at this from a culture change, what Dr. Burton talked about from the medical side. We've got to look at it from law enforcement, we can't arrest our way out of this problem. We've got to look at it from the treatment side. We've got to find more facilities. We passed on the slide about the HOPE Initiative, but in the Roanoke Valley, we do have the HOPE Initiative that Janine runs. And, the key thing is, if you know somebody, if you have a question tonight, do not leave here without talking to somebody. That's the worst thing that can happen. If it's you or your family member or whoever, talk to somebody. We're going to ask all the speakers to come up, and we're going to have a little question and answer period. I know time is close. We actually did a lot better than we did last year as far as time. But if I can have all the speakers come up and have a seat, and we'll take some some questions and answers. But, you know, again, we've got to change the culture, and we've got to change that stigma that says a person who's an addict is a criminal. Because that is not, they don't equal anymore. And we've got to get our heads out of the sand, and we've got to look at it differently. But we also got to think about, you know, what you learned tonight. And we tried to give you a big smattering of it. You know, I hope every one of you goes home and looks in your damn medicine cabinet. Okay? And think about what Joe said. Who comes into your house? And if it's not a family member, but it's a service provider, how come they always got to go to the bathroom? And then you don't know to look for those pills. Okay? Now, I'm not picking on service providers or things like that, but I'm just saying we've got to change the culture. And one final thing before we take questions. And I won't get it tonight because I'm going to tell you, but just about every time we do this, someone says to me, "But Tom, you know, I keep that medicine around in case I need it or a friend needs it." And I always say, well, you know, you just admitted to a felony that carries 5 to 40 years to a Commonwealth's attorney. You know, and it just, but that's the culture that we've got to change. Okay? Let me make sure I covered all my notes. And the final thing is I want to say is we're here. The title is great, Continuing the Community Conversation. We've got to continue it. We need calls. We need your church. We need your school. We're working on getting back into schools. We got into every high school last year. We're going back for round 2. We will go. We have a great team that will go and give this message, but we've got to continue to get it out. So every one of you need to talk to 5 people, and they talk to 5 people. Call me, call somebody. We'll get out and talk to you, and we'd be glad to do it. Okay, questions? And Debbie Bell, our assistant, is going to...
Hi. I appreciate everybody that spoke tonight. And my question is about, my 15-year-old grandson thinks pot is no big deal. And he's admitted to using a few times. He's in middle school, misses a lot of school. But I will tell you, the impact of losing a family member has not made an impact on him. My 27-year-old son overdosed 6 years ago. And you would think that he would listen. I work in the mental health community. I work with substance abuse. I'm putting peer support specialists in the emergency rooms at Lewis Gale within the next month to work with people that are just retired from Narcan. So it's happening somewhere. But when it happens in your family, and you got a kid who's saying it's not going to happen to me, where do you begin? Because I'm so close to the tree that it's hard for me.
Well, I want to address it because, I mean, I've been a prosecutor for going on 20 years, and I was a defense attorney for a couple of years, too. And, you know, we all look at things differently. And, you know, I was a regional drug prosecutor out of Roanoke City for 6.5 years, and back in the 90s, it was crack cocaine. But everything then was the gateway drug of marijuana. And again, as our slide showed, only this changed it a little bit. This changed it that we had much more people going in through the prescription drug route. But it's still, the marijuana is an at-risk behavior. And, you know, people say, well, Colorado's doing it. Well, you know, they can have it. But I think you'll hear from law enforcement that Colorado's making a huge mistake. But why do we want another? And I always hear this, people say, well, it's just like alcohol. Why do we want another damn alcohol? Alcohol causes enough problems. Why do we want another one? As a prosecutor, I'll tell you 3 things about people, most people I deal with who are charged with marijuana. They don't work, they live at home, and they don't drive. And if that's what we want in our society, give everybody some marijuana. If that's what we want in our society, give it to them. But our culture, what we talked about, says it's just pot. I think it's dead wrong.
Address this part. So as someone who's not very far removed from the same 15-year-olds that thought that it wasn't a big deal, I will say that some people use marijuana and use alcohol and never get to this point. It doesn't necessarily, using marijuana does not necessarily mean that your child is going to be an IV heroin user. However, just like you said, it is an at-risk behavior. If your child is wanting to change the way that they're feeling right now, that can lead to other things. What I would say is, I want to commend my parents and any parent that is going through watching their child make bad choices. Some of that is a part of being a young person, experimentation, using substances, wanting to fit in, and being defiant and not listening and saying, hey, it's not going to happen to me. 15-year-olds are invincible. But as a parent, my parents watching that, they continually made that unacceptable. When I was using, sometimes we do have a culture, well, it's okay. It is just pot, and I'll let them, if they're doing it in the house, with me watching them, isn't that better than them doing it? And I will say that the fact that my parents made it unacceptable, that every time they caught me, there were severe consequences. I thought that they were just being really hard on me. And the fact that they did not enable me once they started, that it's seriously a problem. Some of my mom's peers were looking at me going, oh, she's just going through a phase. She's just in college. She's just doing this and that. And my mom knew. As a parent, I think no, something is wrong. When when it goes beyond experimentation, when their behavior is becoming something terrible. And she made careful choices, very difficult choices, not to enable me. She said, no, you cannot stay in this house. No, you give me your key. No, we will not. I'm not going to give you money. Are you crazy? No, I'm not going to co-sign for an apartment for you. And it was those choices that led me to a place of desperation faster. And as a parent, I think that's really hard to hear. But go with your gut is my answer. And, if it's unacceptable to you, hopefully down the line it will become unacceptable to your child. So.
I'll touch on it just a minute, just because we're talking about marijuana. I call it the "it's just weed" attitude. I've talked about it in several presentations, and I've heard it from a million parents. It's just weed, no big deal. So let's put it in these terms. The weed today, in 2017, is not the Willie Nelson weed, folks. Okay? It's not. The THC levels in the high-grade marijuana, which is what the young kids, the adolescents, and the high school age kids are smoking. Do you know what the THC content of that marijuana is today? Anywhere between 18 and 30%. Okay, so let's take that a step further. Now they're getting into the butane hash oil, what they call honey dabs or butter, shatter. You hear a bunch of different things. All that is one more process where they take a solvent, okay, they put it in a cylinder full of that high-grade marijuana, and they extract the THC onto a hot plate. They do a little bit of a cooking process. You can do it in the kitchen, okay? And they get that raw THC, and they call it honey dabs, just like a little piece of yellow glue. And they put that on a smoking device and smoke it. Do you know what the THC levels are in that? 95%. Reaching 85 to 95%. All right, so most of you probably haven't heard of this yet. Now there's a new product called rosin. All right, so they take 2 hot plates, they take parchment paper, all right, and they'll take marijuana, and they'll take those 2 hot plates on that parchment paper with that raw marijuana and squeeze it just for a short period of time, okay? And you release it, and there's tiny little gold crystals on that parchment paper. That's even got a higher content of THC. One step further. How many of you heard of fentanyl-laced marijuana? It's coming. It's coming. So when you have that tough talk with those kids, remember, if you get that joint, at this point in time, folks, you never know what you're going to get. So it's just weed attitude. Be real, very, very careful with that, okay?
Next question. Sure.
There you go.
Well, thank you for speaking. This, what was it, Narvan that you were talking about earlier, Narcan? Now, is that what is given to someone who has been on the opioid or heroin, and they only have like a minute to give it to them? I've heard something about you only have a minute to respond or they die. So is this what?
Yeah, great. So naloxone is the reversal drug that you hear about, and the commonly used term for it is Narcan. And basically what happens with opiates, is they bind a receptor in your body that ultimately affects neurotransmitters to the understanding and the experience of pain in your body. So if we can bind that receptor, then it reduces the experience of pain. So if you come in my emergency department with kidney stone, hope you don't, we'll give you some morphine or maybe even a little fentanyl if you need it, or some other opioid. It's not unusual at all to bind those receptors, and then and that will decrease your pain experience, which you will want with a kidney stone. Now, the way naloxone works and the way opioids kill people is opioids, not only that little idea that I gave of a little bit of morphine or a small amount of fentanyl to reduce pain, large doses of opioids completely blanket all of those receptors. And then not only do they reduce the pain experience, but they reduce your body's interest in breathing and motivation in breathing. It's very important for your brainstem to be functioning, and when you block all these receptors down, your brainstem says, oh, I guess I don't need to breathe anymore. And so you stop breathing. You stop breathing for somewhere minimum of 6 minutes, maybe as much out there as 12 minutes, and eventually you'll go into cardiac arrest. You'll start suffering brain death, right? And then you'll also suffer heart death, and your heart will end up going into cardiac arrest and your heart will stop. And then that's a full-blown death, okay? So that's where the idea of this kind of 6-minute window or 8-minute window comes from, that if you're in full-blown respiratory arrest, you're not breathing, we've got about probably 6 minutes that your brain can tolerate and that your heart can tolerate with no oxygen and no breathing before you go into full-blown cardiac arrest and your heart stops, and then it's too late. So it's a very, very narrow window. So that's part of the argument for naloxone, is that if we can get it in the hands of users or officers or other EMS personnel, then that reduces the time, the downtime of waiting on an EMS provider who uses it. Now, there's other arguments against that. We talked about enabling that Agent Crowder alluded to, but that's the idea behind Narcan. Now, finally, the way Narcan works, and I'll just close out the loop here, is what naloxone does is it goes to those same receptors that are already locked up with the opioid, and it unlocks them, and it competes for that same receptor, and it wins. It displaces the bad stuff, which is the fentanyl, the heroin, whatever the opioid is, and it locks onto that receptor, and it blocks anything else from getting in there. And then the really amazing thing about the naloxone is, not only does it lock onto that same receptor, but it doesn't stimulate it and reduce that pain experience or reduce your breathing or any of the bad effects that you have from opioids. It just locks onto them and blocks them, shuts them down. So that's how it works. Now, naloxone only works for about 20 to 40 minutes, and then it's all gone. So that's a problem when you have long-acting drugs. And then when you have super pure drugs and certain drugs that really lock onto that receptor really well, it's hard for the naloxone to compete. So when you hear about naloxone becoming less effective, it's because the drugs are getting so powerful and their adherence, their affinity for that receptor is so high that the naloxone can't displace them.
I have a question as far as that goes. So that means like the half-life of an opioid pain medication is like roughly 4 hours or something like that?
depends upon what the opioid is. So, so the real big high that people get with heroin, the dangerous front end of that lasts for 5, 10, 15 minutes where they can go into respiratory arrest. But then you come down off of that over a number of hours. And then if you look at different drugs that are opioids that we use, everything from, for example, oxycodone or hydrocodone usually has a half-life of about 4 hours. On the other hand, something like MS-Contin or Oxycontin, which is a long-acting form of oxycodone, can last 12 to 24 hours. And again, that's just the difference in the half-life of that drug before it gets broken down.
Well, that's what I was saying. So if they took it and let's say they overdosed early in that half-life in the effect of the medicine, and then they were given Narcan, and then so the Narcan lasts for 40 minutes.
Yeah.
But the effect of the drug could last for 3 hours after that.
Yeah.
Does that mean they can, in a sense, overdose again?
That's how my first methadone patient who overdosed that I treated, how they almost died right in front of me. Because what happened was I saw them and I said, oh, another heroin overdose. And somebody said, no, I think those kids are into methadone. It was 3 kids who went to a high school party, and there was a lot of methadone on the streets that year. And they decided they would go to a pill party and pop some pills. And they popped methadone. These are kids who never had opioids before, and they pop methadone. 3 of them go into respiratory arrest at the party. 1 of them goes into full cardiac arrest. And as we're treating them, we then learn, oh, okay, it's methadone. And I was thinking, oh, naloxone, I'll just reverse it and we're good to go. But you're exactly right. The methadone lasts for about 6 or 8 hours. So what happened to my patient after about 40 minutes when the naloxone wore off? They went right back into respiratory arrest. And fortunately, they were still in the emergency department. We saw that happen right in front of us, and we gave them more naloxone and then put them on a continuous naloxone infusion. So your point is that the naloxone for longer-acting opioid drugs, the naloxone, you have to basically keep it in a continuous infusion.
Hi, I have a 16-year-old and has had a little bit of a history of mixing prescription cough medicine in with some Sprite, which I understand is called lean. And he was caught with that. He did it right in front of his friends at lunch, and he was disciplined for that. This past summer, he has admitted to us to smoking pot and was like a lot of what they say, oh, it's no big deal, you know, I'll quit before school starts, like it's not even a big deal at all. I want to know as a parent, and my husband as well, what we need to be doing right now to help him and to intervene, because there's so many like things out in the community and things like this that we attend. You know, I could do the counseling, or I just want to know the best way to approach this before it gets worse, because he went to counseling for the school sent him to counseling, and he's scored high on addictive behavior. So I feel like we need to intervene now, probably before now, but I want to stay on top of this. I want to know what to do right now.
I think you need to see this lady right here.
We've got several people in. I'm Nancy Hands, Executive Director for the Prevention Council, and my colleague who oversees it in the city, where is Tracy? And there's Tracy. She's with RACEC. So, and then we also have, where's Tony? Is Tony Kyer still here? Tony. So this depends on probably where your son goes to school. It's in St. Laurent. Okay. So I would definitely go back to the school, but we can talk to you afterwards about different resources. I would say those are very serious red flags. Because I hope everyone in here knows, I know that I'm going to pick on Virginia, who's my intern, and Virginia, at what age is the brain fully stopped growing? 25 to 28 years old. So some of this is really to really understand that, yes, it could be some experimentation, but it's high-risk behavior, and it is beginning to do things that will be changing his brain. And you to have those red flags and get this quickly to someone and continue to is the most important thing. But we can actually, I can give you some names to go to. And but in the county, we have Tony Kyer is she is SAP, and she can talk more about what they do there. Okay. All right. Anything else?
The other thing I would throw into that is, first of all, a little caveat. I grew up not far from here in southern West Virginia, so sometimes I get a little carried away. And this is one of those that gets me a little carried away, is first, just because your doctor prescribes it or just because it's on the shelf doesn't mean A, it's effective, or B, it's not harmful. Cough medicines, the primary foundation of prescription cough medicines is codeine, which is an opioid. So it's a highly addictive substance. 1/6 of the population in the United States doesn't even have the enzyme to break down codeine in your body, and as a consequence, it becomes a toxic substance. So if I ask the audience tonight, how many of you are allergic to codeine, I guarantee you 10 or 15 people, 5 people would probably raise their hand. You're probably not allergic to it, you just don't have the enzyme to break it down. There's never been a single medical trial that has shown codeine as a drug or cough suppressants as a therapy to do anything in terms of promoting longevity or better health. Quite the opposite. The side effects are terrible, and they're frequently more likely to have side effects. Now, there's still somebody though who's going to say, "Yeah, but it works for me, and I don't want to stay up coughing all night long." Fair enough. Maybe it works for you or somebody you know, but for goodness sake, don't leave it on your in your pantry or in your medicine cabinet. We all do that, and when Agent Crowder talked about putting meds in that little bottle that I know you got at home in your medicine cabinet for that time that you know is out there when you may harm yourself, you're going to cut your leg on the lawnmower or with the circular saw, you're going to cut your finger off if you're a middle-aged male experimenting with power equipment or whatever it is, okay? You're saving those pills for a rainy day, and my friend, nowadays you're just as likely to now be a drug dealer to your family or your family's friends, because when they come over, some of your family friends and some of your family, they look in your medicine cabinet and they swap out the pills in that rainy day oxycodone bottle for the ibuprofen or the aspirin pills you got on the second shelf. And then they pocket the oxycodone and out the door they go, and they call up their friends and they say, "Party, we got some pills at grandma's house." Take that stuff off the shelf. Don't worry about a rainy day. Come see me in the emergency department or in the urgent care, or put some ice on it or something like that. Don't worry about that rainy day. It's too risky behavior. And back to where I started, cough syrup is one of those that nobody finishes cough syrups, and that's why you got it on the shelf, And so it's so it's really common for people to keep that around, and it's a terrible, terrible drug. In my days, 25 years ago in Pittsburgh, we used to call certain cough syrups dope on a rope, because what people would do is they would take a little string or a rope, they'd tie it to the top of the cough syrup bottle, and they'd spin it real fast like a centrifuge, and what happens is all the codeine settles out to the bottom of the bottle, and you pour all the syrup off the top, and you got a nice, sweet, wonderful, dense codeine concoction right there out of your syrup bottle.
Let me bring up a drug. Is that on? That, and I don't know how the doctor here would take it, but one of the cleanest times and one of the best times that I had with Jordan was on a drug called Vivitrol. Vivitrol is a drug that it's very expensive. I wish we could get these things down, but I had good insurance, and Jordan was on Vivitrol for 1.5 years, some of the best times we ever had. And it's a shot that you take, and it like you said, it stops the effect of the opiates, so you won't take them. And she had it for 1.5 years, and then my insurance ran out, and it was like $1,500 a dose, so a month. but my insurance paid $800 a month, and Vivitrol wrote off the rest of it. So if that is something that we can ever get under control, I think it could be a salvation to a lot of people. Jordan was on it, but she ended up doing, later on, but she was clean for a couple of years. But Vivitrol, I think, is something that really could help.
One more thing before we move on that I just want to add is that what I would like to see as a young person in recovery is that we're now moving toward getting peer-to-peer support in emergency rooms. We're moving towards getting peer-to-peer support in rehabilitation facilities. Something that I would like to see is peer-to-peer support in schools. I feel that as a young person, I'm not too far removed from kids who are 15. I speak their language. I know the drugs that they're using, and I feel like sometimes they're hearing messages from, DARE officers or RASAC or from school counselors, and they're like, yeah, but you don't really know what's going on. Maybe if they hear a voice from somebody who I know exactly what's going on, and I can tell you where it can end you up. And so I'm hoping that maybe we can move towards something like that. Talk to Scott Abib, talk to Dr. Siebert, talk to Artis Ledbetter, talk to some voices in the Salem community, and wherever you are and go to school, if you feel like this is a good idea, talk to some school officials that can hear you on that, because I feel like there are parents, I know, there are parents, there are teachers that are affected by the disease of addiction that might band with you on that. So. Thank you.
This has been excellent, so thank you so much. I kind of have a two-part question. I'm interested in the incredibly pervasive prescriptions of opioids, sometimes layering of opioids, and what kind of work is being done with not just the ER, but prescribing doctors just in the county for things like chronic pain management, alternative complementary care. There's sort of a wide array of options for pain management and what's kind of being done to get the oxycodone just out of the cabinet altogether. You don't even need to lock it up because it never made it in there.
Yeah. So what you're talking about is kind of generally viewed as alternative therapies, but also non-opioid pain-related therapies too. There's a lot of interest out there in other things that we can do, both for acute pain and chronic pain, and I think you'll see more and more efforts. I'm a little skeptical about my enthusiasm for those efforts, and that's somewhat because for about 15 years I was a researcher, and one of my primary areas of research was pain and analgesia. And so I spent a lot of time reading reports and doing a lot of studies and investigations on alternative therapies. And there is a role for many alternative therapies, absolutely. Everything from hypnosis therapy to massage therapy to non-opioid prescribed medications, herbal therapy. There's a role for all that, but it all has to be tailored to that individual, and it's hard to come up with a comprehensive solution for a whole population. And it's also hard as a healthcare system to get into that business, I would say, because it's not a business we know a lot about. And in one of my former hospitals, we created a whole division of alternative medicines and alternative therapies. So if you came in the emergency or in the hospital, you might have massage therapy and you might have music therapy. So I'd like to see more healthcare systems get into that, including ours. We're barely putting our toe in the water of it. But a lot of the reasons why it's so challenging is there's just not real good evidence on who responds to what and how you apply that. So I think we got to keep up the efforts on that and continue looking for solutions. But it's not a comprehensive solution that's going to fix this problem, is kind of what I'm saying. It is part of the problem, but it's a small part of the solution.
Well, we talked about culture change, and the culture change of the medical community is going to take a while too.
Yeah.
So we've got to look at that. I do want to correct one thing Mr. Gilbert said. The that I kind of cringed at when he talked about, putting the medicines down the toilet. We don't do that anymore. So we're not endorsing that. But we do have drug takebacks, and I think one's coming up at the end of October. So they're all around, so go through and get those drugs out. Also, you can go any day, Monday through Friday, to the Roanoke County Sheriff's Office, which is, I guess, the back entrance is back behind Mac and Bob's in Salem. They have a drug box right there they'll take. So please get the drugs out of there. We're going to close, and these people will be down here for questions. We appreciate you coming out. Tell a friend. If you want us to come to your organization, your church, your school, whatever, call me, call Nancy Hands, call Janine, call somebody, and we will come out. But we really appreciate you coming out tonight. Thank you.